Yes, and hello everybody. It's a real pleasure to talk to you today. So I'm a professor of mucosal infection at Imperial College, but very much focused on developing vaccines. And actually in 2018, we presented at the World Health Economic Forum on the potential of RNA-based vaccines as being a rapid response to potential pandemics. And interestingly, in 2018, I think we had 30 people in the audience, despite the Economic Forum being a massive conference. And most of those 30 people were wives or husbands of the official delegates. So it's interesting how it didn't actually catch people's imagination or attention at that stage. And that's probably because we've been predicting that something like this event would occur for the last 10 years. And people had got a little bit complacent saying, we know it's coming, but it doesn't feel that it's immediate. Well, of course, you know, the last year and more has been a very sobering story. And it's, you know, it's interesting really that we're only a year and a bit into this pandemic, thinking back to those events in Wuhan and the initial description of cases actually in December of 2019, hence Covid-19, leading to an epidemic in Wuhan. What's really very interesting now is the really forensic molecular tracing of the virus. And if you like, that's a very strong smoking gun showing that it came from bats, most likely through pangolins to humans. And, you know, this type of potential pandemic was not unexpected. It's something that's been on our horizon for a while. And if you think about, you know, looking back in relatively recent history, Marburg came through bats in Uganda, Ebola, 1976, first in Democratic Republic of Congo, Nipah, 1999, Malaysia, SARS, bird flu, MERS, swine flu. We've seen all these potential spikes coming through. And it's likely that these types of events are going to become more frequent with the increasing density of the human population, but also our increasing encroachment on natural habitats. Well, what is very interesting, of course, is looking at how the pandemic then took off, because in reality, in Hubei province, where Wuhan is, actually the very strict lockdown, enforcement of wearing masks, tracing system, actually pretty much controlled the local epidemic by March of 2020. But by that stage, global travel had already had a significant impact on the spread around the world. And we now know there's 120 million cases, 2.6 million deaths, and still rising. What I think is interesting is those countries that had previously had to respond to MERS.
Sorry, Robin, can I just, for the record, you said there's 120 million cases, sorry, and 2.6 million deaths.
2.6 million deaths.
Sorry, my mistake. Thank you.
Yeah, that's fine. You know, those countries that have responded to SARS previously probably put in place methods that they already had seen worked in the context of SARS more efficiently and more able to control the number of cases than other parts of the world. And other particular successes are, of course, some of the more geographically isolated countries. A typical example would be New Zealand. Interesting to hear about the Maldives later. But obviously there are examples where the virus has been controlled quite well with existing measures that could be put in place. But by and large, a huge amount of faith and expectation has been placed on vaccine success. And that has been luckily a great success story. We need to remember that, you know, vaccine development typically takes about 10 years. And when in January we started thinking about vaccines, the WHO was looking for a vaccine that had 50% or greater efficacy. And it was predicted that most vaccine candidates had about a 20% chance of success, so 80% chance of failure. And in reality, it's been much better than that. And we have seen some of those vaccines approved within a period of 1 year. Now, one of the things that made that happen actually was that the academic Chinese scientists made the sequence of the virus available to the world on the internet. And that gave everybody the chance to start working on vaccine candidates around the world. And that was really also increased by the fact that we had had those experience with designing vaccines against MERS and SARS. So we knew a lot about the spike glycoprotein, the target for most vaccines, and how to stabilize that molecularly. And occasionally people misquoted that we never developed a vaccine against SARS. We certainly did. The problem with SARS was that it disappeared before we could test whether vaccines worked. So it wasn't a failure in the vaccine science. And now we have multiple different candidates. I think the other thing that's quite sobering is the cost, because those vaccines that have been approved, Moderna, BioNTech, AstraZeneca, Johnson & Johnson, they have all invested at least $2 billion up to $8 billion in getting them past the post. And, you know, like it or loathe it, it did require that level of funding to move quickly. And so we certainly need pharma companies, we need commercial investment to be able to respond. Obviously, they've come through with different levels of efficacy. So from 60% up to 95%, extraordinary high levels of efficacy at preventing disease. Now, it's important to remember that all these vaccines have been tested against preventing disease. We don't completely know their efficacy against transmission. We are getting data through all the time on transmission, but transmission will be important to understand how well they can be used to achieve herd immunity, what level of population would need to be vaccinated in order to reach that goal, if that goal is achievable. And they come with very wide differences in cost, from $4 for the course up to $37. And that has impact on global access and availability. Different storage conditions. So you know that some of the RNA vaccines have to be deep frozen. That's really not viable in a low income setting, where we know that it's that last mile of getting the vaccine from the clinic into somebody's arm that is most important in that context. And other things that we don't know right now is long-term safety. I mean, these vaccines do look safe. There haven't been any shortcuts in testing them, but we don't know how long, you know, what long-term, very rare cases might be seen. And so surveillance is still going on in terms of the safety of the vaccines. We also don't know in terms of how long protection will last. Will it be a year with annual boosters? Will it be 5 years? Will it be 10 years? That's a very open question and has important strategic implications moving forward. And then people really fall between two extremes. Either they think vaccines are going to solve everything and they're overconfident in vaccines and think with a 2-shot program, if they've got 1 shot of the vaccine, they're already protected, which they may have a level of protection, but they won't be fully protected. Or they go the other way and they don't believe that they need a vaccine. I'm a young adult. My risk of getting sick is low. I don't believe in vaccines. I don't necessarily believe in COVID-19. Why should I get vaccinated if I don't think I'm going to get a benefit from it? So those are things that we still will struggle in terms of getting vaccines out there and using them as a tool to control the pandemic. The other big challenge is really global access. We can, vaccinate certain countries. You could sit in a country like the UK where the vaccine rollout is extremely efficient right now. We suspect that most adults in the UK will have had a dose of vaccine by this coming winter. But that's not going to help things if the rest of the world has not seen the vaccine and the virus can still be out there and potentially create other variants. And so global access is going to be a major hurdle, with some countries predicted not to get many doses of any vaccine until 2023, which is quite daunting. And I think that will change the way vaccines will be made in the future. So people now are really debating whether we're talking about elimination of a virus or control of the virus. And theoretically, you could drive down this virus with very draconian measures over time if they were universally adhered to by every individual across the planet. Whether that's feasible or not is something we might get into in the discussion. The other pole is just to say we can live with this virus, we can vaccinate vulnerable populations, we can reduce mortality and hospitalization very dramatically. And is there a sweet spot at which the number of deaths, although tragic, are acceptable, given that we know that there are a range of viruses that are, killing people who are an elderly population, influenza, RSV, for example. We're not locking down whole of society each flu season. And those are questions we might like to look at as well. And we need to remember that using vaccination only as a tool for elimination is a pretty hard job. We managed to do with smallpox, and the smallpox effort was an enormous undertaking over several years. We're trying to do it with polio, and we still haven't quite got there because there are pockets where people are still not getting the vaccination and the virus is still able to hang out. So a vaccine approach to eliminating COVID-19 would be extremely challenging. Some of the other issues that I think people are less cognizant of and are also quite concerned about are the issue of variants. And I think one thing is important to know: variants are a strategic danger at this moment, but they aren't a strategic danger that can't be overcome with vaccination. Because what we're seeing with COVID-19 is that there are some mutations, and the most significant one right now is the one that's at position 484 in the glycoprotein that makes it more transmissible. And some of the vaccines may be less effective against that variant. That doesn't mean vaccines work today and they fall off a cliff. They just start to lose their efficacy. It's easy to develop new vaccines against those variants. The good news is, with COVID-19, is that we're seeing an issue of converging evolution. What that means is the same mutations are cropping up independently in different parts of the world. It's not changing as fast as influenza, and we can keep ahead of influenza changes on a global basis and an annual basis. And it's luckily not up like HIV, for example, which has divergent evolution and goes off in every direction possible. So the threat of variants is real, but it's not a threat that is not possible to address. It's highly possible to address. And perhaps as we look to the future, it's not just COVID-19, it's the fact that there will be other viruses out there that will be infectious threats, and we will have to go through the same process again. All bacteria, multi-drug resistant bacteria, still represent a massive threat for mankind. And so we need to make sure we learn the most from the lessons of this current pandemic.
Robin, thank you. I mean, it's always good to finish off, and we need to learn the lessons learned, don't we? We're very good at identifying lessons. I'm not sure we're that good at learning lessons, and certainly I have a feeling that's something we're going to loop around on. I mean, there was just so many points there that came up. The two that hit me because they are relevant to any crisis management. And the first is last mile delivery. You know, if you're in an earthquake or if you're in a pandemic, if you're in a flood, you can get everything from here to there. But it's to have that last delivery so you actually have impact. That's the hard bit. And then, of course, the other bit is, which I'm sure we'll talk about, is that science doesn't operate in a vacuum. You know, there is a political, there's a social, there's an economic, and there's this dance of energy. It's always negotiated solutions, isn't it? I look forward to coming back to that. Thank you, Robin, for that. Absolutely brilliant.